So we continue the prostate cancer part 15 and the radical prostatectomy. Radical prostatectomy surgical technique. Radical prostatectomy is a surgical removal of the entire prostate and seminal vesicles, and it may be accomplished by robotic, laparoscopic, or open technique. So three methods might be robotic, laparoscopic, or open technique. Open approach include retropubic, perineal, and transsacral. This is the three methods of the open prostatectomy. Open and robotic technique have a similar cure rate and similar risk of sexual and urinary side effects. Open, perineal, and robotic approach result in less blood loss than the open retropubic approach. Neoadjuvant androgen deprivation does not improve disease-free survival overall. Thus, the neoadjuvant androgen deprivation is not recommended before radical prostatectomy. Nerve sparing. The neurovascular bundle course posterolateral to the prostate and recomposed of the cavernous blood vessels and nerve which promote erection. During nerve sparing, the neurovascular block, these neurovascular bundles, are preserved by dissecting them away from the prostate. Patency or potency after radical prostatectomy is better when nerve sparing is performed. Bilateral nerve sparing results in higher chance of patency than unilateral nerve sparing. In appropriately selected patient, cancer control is probably not compromised by nerve sparing. Intraoperative frozen section of the prostate may help exclude cancer in the neurovascular bundle. The ideal candidate for nerve sparing would have clinical stage T1 or T2 and PSA less than 10, Gleason score less than or equal 6, small volume cancer on the prostate biopsy, and good preoperative patency. So this is the ideal candidate for nerve sparing. Who are the ideal candidate for nerve sparing? T1 or T2, PSA less than 10, and Gleason score less than or equal 6, sample volume of the small volume of prostate cancer in the biopsies, and good preoperative potency. This patient tend to have organ-confined cancer that has not invaded the neurovascular bundle. When the neurovascular bundles are resected, nerve grafts does not help restore erection. Bladder neck preservation. Bladder neck preservation does not improve the final degree of urinary continence, but it may prevent continence to return sooner after surgery. Bladder neck preservation reduces the risk of bladder neck contracture. Cancer control probability not compromise intraoperative bladder neck biopsies can be performed to exclude residual tumor. Pelvic lymph node dissection or PLND. Very low risk and low risk pelvic lymph node dissection is an option in this mainly because the risk of regional node metastasis is very small. Normogram that predict the risk of regional lymph node metastasis can be used to help decide on whether to perform pelvic lymph node dissection in this male. Intermediate risk, the NCCN recommend the pelvic lymph node dissection if a normogram shows a 2% risk of lymph node metastasis, whereas the EAU recommend pelvic lymph node dissection if normogram shows that's more than or equal 5% risk of lymph node metastasis. So less than 2 show the percent of 2% by NCCN show that it is recommended to do pelvic lymph node dissection. And EAU mentioned that if more than or equal 5% lymph node metastasis is an indication for lymph node dissection. AUA recommended the pelvic node dissection unfavorable intermediate risk, but the pelvic lymph node dissection is optional in favorable intermediate risk cancer. So for unfavorable, it is recommended, but pelvic lymph node dissection is optional in favorable intermediate risk cancer. High risk, the AUA, EAU, and NCCN recommend pelvic lymph node dissection for high risk group. The EAU and NCCN recommend performing pelvic lymph node dissection using the extended templates, while the AUA mentioned that the extended template as an option. The limited pelvic lymph node removal of lymphatic tissue in the area bounded by the external iliac vein anteriorly, the obturator nerve posteriorly, and the origin of the internal iliac artery proximally, Cooper ligament distally, the bladder medially, and the pelvic side wall laterally. Extended pelvic lymph node consists of a limited pelvic lymph nodes plus removal of the lymphatic tissue posterior to the obturator nerve. The boundaries are the same as limited pelvic lymph node dissection, except the posterior boundary is the floor of the pelvis. The extended pelvic lymph node dissection will detect metastasis twice as often as limited pelvic lymph node dissection. Complication more often occur with extended pelvic lymph node dissection. Removal of the lymphatic tissue anterior and lateral to the external iliac vessels increase the risk of the lymphedema. Therefore, dissection in this region should be avoided. It is unknown if survival improved by removing lymph node metastasis. However, knowing if the regional lymph nodes metastases are present can guide subsequent therapy. The complication of pelvic lymph node dissection. Complication from pelvic lymph node dissection are rare. However, the risk of complication is higher with an extended pelvic lymph node dissection. The complication of the pelvic lymph node dissection include iliac vessels injury, lymphocytes, if the lymphocyte is symptomatic or infected, place percutaneous drain. Send the fluid for spot creatinine and culture. Spot creatinine will be 25 to 45 to 450, 25 to 450 milligram per deciliter for urine leak, urinoma, but it will be similar to the serum creatinine for lymphocyte, 0.5 to 1.5 milligram per deciliter for normal renal function. Remove the drain when the output is minimal and infection has resolved. If lymph output persists, consider infusing sclerosing agent into the lymphocyte. Example for this doxycycline or diluted povidone iodine, or performing peritoneal window open or laparoscopic. Consider obtaining follow-up pelvic ultrasound to rule out recurrence. Leg lymphedema, if leg swelling occur postoperatively, obtain lower extreme Doppler to check for DVT. If this is negative, obtain pelvic CT or ultrasound to check for lymphocyte. Obturator nerve injuries, if the nerve is severe, it can be re-approximated. Obturator nerve injury might impair the leg abduction. If the symptom persists, consider obtaining pelvic CT. Lymphocyte may be compressing the nerve and referral to the neurologist. So this is end of